welcome back to the podcast. Today we have a really exciting guest, and I'm excited to talk to her. We have Noriana Prior. She is a dental hygienist and she is a PerioView expert. She has tons of experience about the endoscope and using it clinically. I've kind of already talked to her. We had a super long phone call kind of planning this episode, and I'm just really excited to share her insights with you. I'm not clinically experienced with the endoscope. I've just used it in school, and just seeing what you see, what you don't see, I guess I should say is a better way to say it, is so impactful. And so I'm excited for you guys to hear her share her stuff. I'm going to let her introduce herself. Noriana, do you want to tell us a little bit about your dental hygiene career and a little bit about yourself?
Yes, thank you, Katie, for having me. I reached out to you just because I knew you were a hygienist in a school teaching perio, and that is my love language. It definitely was not my love language at the beginning of my career. I graduated from a relatively small school in southern Georgia, and at that time, hygienists could not give anesthetic. I worked in a pedo office out of it wasn't COVID, it was the recession back then. So it was even harder to get a job. I worked primarily in pedo with Medicaid, Medicare, really unique patients, really unique demographic, and definitely it was serving an underserved community. So I really was exposed to a lot. During all that, I got burnt out on the pedo, really burnt out on pedo. I then moved to Atlanta where my horizons were a little bit opened there into different, perio offices, cosmetic offices. I saw a lot more. My husband was in the service, so I didn't last in Georgia very long until we moved to North Carolina, practiced in North Carolina, went back to Georgia, then to Washington, which I had to go back to school. I had to go back to school and do my restorative, my local, and my nitrous, and whoo, what a game changer. And then also being around hygienists there that had been doing all these things since the 70s, right? And here I was once again not exposed. So much growth potential happened out there. And then we move again, and now I'm in Boise, Idaho. So I've held licenses in 4 different states, but burnout has really always led me to every change in my career. I was definitely burned out. I started temping a lot when I was in Washington. We go through these periods, right? Because sometimes it is Groundhog's Day for us. And I started attending the local component meetings and networking. And there was a hygienist that worked in a perio practice that she had this technology and it was sitting in a corner. So I said, challenge accepted. I had read about it in a magazine. I thought I would never see it in all my career. Like I thought maybe it was only in schools or perio practices. And I befriended her and I walked into that office and demanded a job for the sole purpose that I was going to teach myself how to use dental endoscope and I was going to see below the gum line. So that's kind of how my journey to dental endoscope came to be. And now it's a part of me. And once you see, you can't unsee. It's really hard to go back and do an SRP without vision. I mean, it gives me anxiety and stress.
Yeah, just the fact that you said what you can't, how'd you say that? If you can't unsee what you unsee, say that again.
Yeah. You can't, like, once you see it, you can't unsee it. So you can't go
Yeah.
back to practicing without vision. And
Yeah.
think about it. We've been doing the same thing for over 300 years, blind scaling. And yeah, once you see the calculus for me, I cried a lot during the beginning. I had just done an SRP and wondered why this didn't resolve. I thought my skill sets were bad, but you can only do so much unless you can see it. You don't know if it's burnished. You don't know if it's, if that's just a rough root surface or it is deposit. So, yeah, I
Yeah.
can't go back.
I know. And so I, like I said in the beginning, I'm like bumping my camera. Like I said in the beginning, I don't have any clinical experience with it, but I do have, I experienced it in school, and it's interesting out on the coast. I took my master's at Eastern Washington, and that's where I got my experience. But just like you said, you can't unsee it, in that I was just like, my goodness. Even the biofilm, the tissue associated biofilm, trying to get that off. And I was using a Cavitron and it wasn't just flushing out of the pocket like, they kind of tell you that it's going to do. So yeah, so that was my experience too. And you come back to South Dakota. And so for people that haven't seen it, it's kind of like you're trying to explain something so abstract that it's hard to kind of get buy-in. And so that's why I'm really excited to talk to you. We're going to learn all about endoscope today. That kind of segues us into our first question. For those of you that do not know what dental endoscope is, can you explain what the PerioView endoscope is and how it changes, I think revolutionizes the way that dental hygienists approach periodontal therapy? So just give us the 101.
Yeah. So dental endoscope, and almost think of it like a perioscope in a submarine. You're allowing vision where you wouldn't normally have vision. It is a fiber optic camera that, depending on which unit you're using, ranges about 1 to 1.5 millimeters. You can insert it underneath the gum line, and you're looking at a computer monitor in real life time, going around, walking around, and seeing either the calculus, the anatomy, granulated tissue, decay, root fractures, all the things. But you're able to simultaneously remove the calculus when you're looking at it, which is not something we've ever done. The technology merged late 80s, early 90s, and has had different generational redevelopments. And so we've seen it evolve to where it is now, with the PerioView being the newest technology on the market, which allows you to record and take pictures, which we've never been able to do that in the last 20 years of this technology, which is a game changer because we know when our patient sees something, it clicks in, right? When we disclose that biofilm, they're like, oh my gosh, I haven't been brushing my teeth. So they're bought into it, and it just helps you help them, motivate them to step up their game or figure out what's going on in their mouth. So, and it comes on a cart, so it's mobile, so you can move it from room to room. It uses water and air, because when we're in the pocket, we have fluid coming out, we have blood coming out, we have biofilm coming out. So it does allow water and air to clean that field of vision out, as well as you're using your Cavitron too. So there's a lot of water involved.
So this was not a question on the list, and so I'm going to tie it to the next question, and then I have just an insight. I just kind of thought of it right now. But so the next question is, how does the ability to see anatomical features specifically? So like you mentioned, you can see the root, you can see the crown. When we're talking in perio class, when we're teaching in perio clinic, the biggest struggle for especially students, but even practiced clinicians, the biggest struggle in determining those 4 or 5 millimeter pockets is their true cal, meaning has the junction epithelium detached from the CEJ and now is down on the root. And I'm just thinking, like, mind blown, if you could actually see that and take a picture of it, would that increase insurance reimbursement for perio, or what would that look like? So that's kind of a two-parter. I'm kind of getting ahead of myself, but how does the ability to see those anatomical features help clinicians, and how does it help the patients understand what's happening? Sorry, loaded question.
No, I love it all. Seeing it, once again, everybody's tooth surface is different, right? Even though we carved the tooth out of soap and we learned on the typodonts, until you see or you feel, right? Because then you see the furcation, not realizing that it's already a class 2. But for some reason, either you were coming in contact with some bone in wherever, right? Because we bob that hoping we're getting the deepest measurement. Or even if some don't use a neighbor's probe, how will you know it's in class 1, class 2? So to be able to see that speaks volumes, because those are hard areas to access. With even all the instruments we have today, they're still hard, and we just, once again, scale and hope that tissue reattaches. The one thing I hope
Yeah.
in where the generation of perioscopes will go, is we'll be able to incorporate measurements. We have AI that can show it on an x-ray. I'm really hoping that the cameras will be able to develop that as well, because that would help with the insurance, right?
Hmm.
Because when you're in the pocket, unless you are taking a probe and seeing the CEJ, you're really not able to see how deep you are. I mean, I can kind of gauge like, whoo, I just got swallowed in. I'm deep. Okay, what made deeper than what I probed?
Yeah.
Because now I'm seeing, but it's just amazing how that, and right, I always thought, even though I had these lectures and I've told patients that the tissue in the bone is like a collar, but it's not. It is a wave and hills and bumps. And how can we adapt our instrument for those waves and bumps and hills? We typically don't. Unfortunately, we use these strokes and we scale and we hope our Cavitron does the egg beater motion to cover something of that surface. So for insurance reimbursement, I think it's great when we find decay under a crown margin that's not showing up on an x-ray. That is of value so much
That's interesting. Yeah.
because you're fighting the insurance companies, unfortunately, because they don't see it on an x-ray. So now you can show them with a picture. And a picture, again, is worth so many more words. A video is worth even a million words. So I think that's where that goes to. I think that's such a two-part question in the sense we're removing the calculus. So we know we've helped one part of the whole solution, right? Because we also have all those other factors that are playing in with perio, but also able to diagnose fractures. A patient could have been referred to the endodontist because of this tooth, and then the oral surgeon, and then back to perio, and then back to endo. And this patient's like, how can you guys not figure it out? Well, okay, it's nothing showing up on an x-ray or CBCT. I'm going to numb the tooth. I'm going to go on an exploration. And I will say 90% of the time, it is a fracture that is causing the problem. But we don't want to pull teeth unless we know that is, right? We want to save them. So
Right.
once again, if for the patient, they're able to say like, oh, that's a fracture. Now I understand why I'm having all this pain. And I just went to 3 to 4 different specialists trying to figure it out. So sometimes that's what we just have to do, right? The rule of elimination.
Yeah, that's awesome. Okay. So you mentioned biofilm and especially calculus a little bit. That's one of the pieces of the puzzle. So tell me about your experience with the endoscope and how it's maybe helped you identify biofilm and calculus in, like you said, furcations or anything, and even burnished calculus. That's what I'm really interested in hearing about is burnished calculus, what it looks like, what it feels like. To me, like that is just a place where the endoscope really shines.
Good old burnished calculus. Never have I ever seen so much calculus at a CEJ. A CEJ, which we can feel, right? But that's primarily where we find it. I think the dental endoscope really also helped me with my instrument adaptation, right? So when I'm doing my perio maintenances, I'm over adapting any instrumentation that I was originally trained. And I go back, if you've ever heard of Anna Pattison, I mean, she teaches her hand scaling course by having this technology to actually see the instrument move and where you need to over adapt or what instruments would be better. Because once again, we were told only a sickle should be used here, but we know sometimes it's better there. I was training a new graduate a couple years ago, and she even said, wow, there's a lot of burnished calculus right under the contact. How do you think it gets there? And I turned to her and I said, I think it's the floss. We have taught patients to shimmy the floss, and some of them get so crazy about it that we smooth that bacteria out and it just is nice and fine there. And when we're going with our tactile sensitivity, it's smooth there, right? So we
Yeah.
don't engage that. And that's where, for her, she really understood interdental brushes and the importance of an interdental brush for every patient and not just relying on the floss. Floss is great. I'm not knocking it, but when we have a lot of it, we typically already have bone loss. We have open embrasures. We need other things, and not all patients are going to floss either. So I think too, it really kind of changes the way we treat patients to individualize who they are and what they need.
Yeah, I am not a big floss proponent, I got to be honest. And I know students sometimes even be like, well, you're not thinking about caries. And I'm like, you're right, I'm not. This is perio class. But to me, floss is good for the what 25% of patients that have healthy periodontiums. I mean, it's not a bulk of our patients that floss works for, and the statistics on floss versus anything else is so bleak for floss. It's just not doing it. Yeah, so I appreciate that insight as well. Let's go into the instrumentation because you kind of brought that up a little bit. What are some improvements? Can you elaborate a little more on the details? What are some improvements you've seen in instrumentation, techniques of yours, or you mentioned Anna Pattison? What are we missing? The average general clinician, what do you think we're not doing?
That's so hard because once again, it's case by case. I will say I was taught majority of my early career was hand scaling only. And I only had the instruments that I had. I didn't know there was a whole different world of all these different files or all these even just langers, right? I was just taught what I was taught. So that helped me using the dental endoscope because I was solely using Cavitron and piezo. I only rarely picked up a hand scaler, and that was typically to curettage some of the granulated tissue out. And that was a Queen of Hearts by PDT makes it. I just love it because it has a longer shank and it helps me in the furcation. So that's my go-to when I'm blindly scaling. And just in my mind, from once again, what I thought I needed to do was just aggressively just go to town and go to town until it was so smooth, so smooth, smooth. And now I realize that with your Cavitron and piezo, you touch it a few times, it comes off really nicely. So
Mhm.
really, for me, it was utilizing more of those instruments and getting away from my hand instruments so much. But then when you look at your hand instruments, what angulation? 17, 18. Yes, baby, you need those. You need some
You
files.
have to. Yes.
I knew I needed more to access that angulations or those furcations, like you said.
Yeah, we see, I'm in a prison clinic. We see pretty severe perio, and we don't have access to a lot of extra things, but the increased angulation of the 15, 16, 17, 18 pair is wild, of the difference of getting to a 5 millimeter and getting beyond that because of the angulation itself. Like, there's no way to get a 13, 14 terminal shank parallel when you're down that deep. Same thing with the universal. Sometimes I'll have students wanting to try to adapt universal. Well, in campus clinic or on an easy patient, I just use the universal. That's all I use. I'm comfortable with it. And I'm like, understand that, but trying to adapt the blade with a universal in a 5 millimeter pocket is just not going to happen. And sometimes they can really feel the difference, but sometimes, going back to the endoscope, like, oh, if you could just see where your cutting edge is, I feel like it would connect the dots a little more, like in terms of understanding, not just because I say so, but because that blade is not going to be, it's going to be so hard to adapt with that deep.
So
Anyway.
hard. So hard.
Yes.
Yeah, because it's like this, and like you said, is your toe touching where it needs to be? Is that angle? And then also too, is your instrument sharp enough or is it
Yes.
dull? That's a big one too. You gotta really make sure you maintain it. I mean, I don't even really think I even learned how to sharpen files. And learning that later on was just a mind-blowing. Or even now the files with the diamonds. Those I love for furcation as well, just to smooth out that fine scaling when I don't have a dental.
Okay, tell me about diamonds. We have a couple diamond files. They scare me to death. Give me some confidence. Tell me your experience.
Diamonds are
How
a girl's best friend, is what I like to say.
they just terrify me. I think I'm so terrified to damage the cementum. I guess I'm very hesitant. So, what do I need to know? How do I have the bravery to dive into that?
I think, and I will always say, go back to your typodont and practice. Pull out the tooth and feel, because you don't need to apply a lot of pressure. And I think once
Yeah.
again, we apply too much pressure sometimes. And even if you go over that a couple strokes, you're being better off than gouging and causing a lot of postoperative unnecessary sensitivity. And once again, these diamond files are all different angulations. So just going back to basics and being like, that won't get in the furcation because it's angled out and I have the wrong way and I need it to go in. I use it when I have vision, I will use the diamond coated Cavitron tip too, because some of that calculus is so deeply embedded into that root surface. You need to stroke that off and smooth and get that diseased cementum off. Definitely. One thing I also was amazed is in this primarily is in the mandibular first molars on that buccal. You have a CEP, which is that enamel kind of projection that goes down into a V, and that goes into the furcation. That is a slide for the bacteria to just keep going into that furcation and keep going into that furcation. And I had, remember, I mean, this was early on when I was learning dental endoscope. I was like, I don't know what that is. Like, is that, once again, I don't remember those basics I was probably taught in school. I had to call the periodontist and he's like, oh, it's a CEP, da 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 da. So once again, I got mentored, I got a lot of help, and he was like, I'm going to smooth that out. And I was like, what? He's like, next time you're going to do this, but I'm going to smooth this out. I'm going to remove that enamel and now we're going to have that tissue heal and that furcation will close right back up. You'd be surprised that is, sometimes I'd see no calculus down there. I'd see a lot of biofilm, but no calculus. But then the body's pulling away because it's that indicator. Our body's like, high alert, high alert, high alert. And
Yeah.
again, every state has different regulatory things of what you can do. So fall within those guidelines and whoever you're working for, right? But we know
Yeah.
once they're gone, you get better success rate. And I can see, same with when I'm working with an implant, because implants, we have so much controversy around implants because there's
Mhm.
different practitioners believe in this, different practitioners believe in that. But if I see calculus on an implant thread, I'm getting it off with an instrument. It's
Yeah.
typically usually Cavitron, which I know can be scary for some
And
people.
yeah, it is scary. In your experience, and that does that calculus come off fairly easy, right? I've heard that. I haven't experienced that.
Yeah,
But can
there's
you see
times,
that?
yep, there's times depending on the threads or how long it's been there. Sometimes it could be a little bit tenacious, but it flies off. It flies off. I think once again, that's where you have to have your angulization of your Cavitron tip. And when we work around implants, we're always really cautious and we just typically just
Yes.
flush it out. The airflow polishers are really great now with the subgingival implant devices they have because that pressure just blows that calculus off the way too. So if you don't have a dental endoscope, I think getting a subgingival air polisher that like an EMS GBT has those tips so you're effectively able to clean those threads, which we're trying to save implants too. The failure rate of implants is so increased right now.
Yeah.
I can go on and on about that too.
I know. And I just wonder how much of that is you ask, and I've said this before in other episodes, and so I don't want to like beat a dead horse, but you ask 20 different dentists about how they want their implants taken care of. Well, I place this implant, this is what I want. You'll get 20 different answers. And I guess that's the frustration is even as a school, we've had dentists on our advisory board disagree. We've tried to do lit reviews, but there is such a wide range of research when it comes to implants that it's hard to come up with a standard. And it's frustrating when your profession is based on a specific standard for a specific topic. It's hard because there are not a lot of dentists that agree.
And right, we see that in our career. Well, I did it this way in one office and the doctor, but then it's also really looking at the doctor and was like, when was the last time you got your knowledge? Because are you staying up
Mm-hmm.
to date with the trends? I mean, AAP is always my go-to there on their website. They have such informative, great research study.
Mm-hmm.
And so I tend to go with their guidelines because once again, every school teaches different, every clinician learns different things, and
Mm-hmm.
that's a hard dance.
Yeah. Yeah, it is. I want to back up to just one thing you said, specifically about the amount of pressure with diamonds, which is totally like that was a few topics back. But do you think that using the endoscope helped you kind of learn how much pressure you could provide with specific instruments, because you can actually see like what you're doing and kind of build that confidence. Like, I know I can apply this much pressure because I'm seeing it, versus trying to go in blind. I think maybe that's why some clinicians are a little bit hesitant. They don't want to damage the cementum. They're just a little more timid when it comes to that. Or what is your experience with that?
I agree 100%. Pressure, but also power of your automatic scaler. We sometimes
Ooh,
keep it at a certain and rarely go up unless it's like a whole lingual bar of calculus, we'll crank it up. I will say the majority of the time, anything I'm seeing underneath the gingiva, I'm cranked up a little bit higher because that calculus has been there longer than we thought, longer than we know. It's so embedded and it's so, and then there's times where I barely just touch it and it flies off. So, but I think for me, it was just adjusting also the power and pressure sometimes, yes, because it is like cement. So you have to keep going at it. But when you don't have vision, it's really hard to gain. Is this enough? Is this not enough? Where's that balance? And I'm once again, a bit of technology. I think there will be something that will be invented that will help us if the future still allows blind scaling. I think
yeah.
give it another 20 years and every single dental hygienist will have a dental endoscope because that will be the new standard of care. Because if you think about in medicine, we are using laparoscopic, we're not cutting people open anymore. We want to maintain and preserve the blood supply. When you have surgery, that blood supply is cut. I mean, it's just, I think where we're going, and I hope I'm still around to preach it, love it, own it, because we shouldn't still be back in, we just need to keep going and growing and failing, right? Some technologies failed, but we learn those lessons to keep, what do we need? I mean, I would love it to measure 100% and get true, accurate measurements because it is hard when there's infection, when there's inflammation, when you're hitting calculus, I mean, there's all these factors, bulky composites where you're having to angle your probe a little bit differently. And you're like, oh, but if that wasn't there, right? So I hope that some technology comes around where we scan and the probing measurements are output. Like, yeah. So I know technology is just going to lead us to treating our patients in
Yeah.
a whole new way, which, yeah. I can't wait for that.
I even envision like just, I guess in my mind, helping a student or helping a hygienist in general decide, like, I have 4 and 5 millimeter pockets. There is some swelling. I'm not sure if I can feel the CEJ. There's that question, right? Is it severe gingivitis or is it perio stage 1, stage 2? I can't quite tell. Maybe there's a lot of calculus, so I can't feel the CEJ. To get down there and see, like, yes, you have detachment of the junction epithelium. That's cal. You can see that. That to me, diagnostically, would be so beneficial, just in the confidence you gain in being confident in your classifications, being confident in what you're seeing and matching it to the perio chart. Yeah, this is so exciting. Anyway, um, we will. I'm just gonna end with one just like follow-up question. Just share. I know you were a trainer for PerioView and still kind of work with them. And clarify me if I'm wrong. So tell me like your favorite story or your favorite aha moment that you had, either working with somebody learning the technology or even you yourself. What is like your favorite story about PerioView?
There's so many stories that's really hard to pick. I think it was, and I would say most of the time it's the patients that don't have to have surgery. You get surgical results without surgery. And not all patients can afford surgery. Not all patients want surgery. So for me, the aha moment was the 9 and 10 millimeter case that I was just crying and drowning in. But I used my dental endoscope, and when they came back, it was 3s and 4s. And I was like, what? Is that really what happened? Like, oh, good for me, right?
Mhm.
And I think to change that mindset as well as you can prevent, right? We are these prevention specialists, but here I am preventing surgery now. Or even if I'm buying someone some time, like they had so much bone loss, they need, some bone grafting, but it's not on their radar. It's not their priority. How can I help them with where they're at? So that's what for me the dental endoscope really does. I mean, and when even seeing all these patients in a perio practice, oh, I had surgery 3, 4 times, right? And you're like, you had that many surgeries for the same thing. How do we stop that? And then going back in there and seeing the calculus that was missed after surgery, because you can't, our loops are not magnified like that. When we flap open, we still can't reach these anatomy grooves. There's so much blood in the way. So there's all those other factors. So for me, it was just finding that interim and filling that void because it was like a scale. You're either going on this way or that way. You have no middle ground for these patients. So that was kind of my aha moment there. And I've trained quite a few people with a different technology called perioscopy. And once again, it's just the faces. The faces when they see the calculus. I've rarely had someone be like, okay, what's so great about that? It's always and you spark a curiosity among your peers that you never thought you had the power to do. So that's for me. And even like we're on the show floor and we're doing it, it is like I could just take pictures of everybody's face, like, whoa, I didn't know, whoa. And doctors too. But I think for us as hygienists, there's something else that just sparks. And if we continue with the curiosity, we'll continue to grow. So I think that helps us prevent that burnout and because we do struggle with trying all the things for patients and wondering why is it not working? Why is it not
Yeah.
working? So I think if we can eliminate the calculus and that biofilm and get some healing, we can then also look at all the other things that are playing in factor, like the microbiome that we can't visually see, right? I mean, look, microscopes are coming in and showing us all these amazing parasites and things, I didn't even think about talking to my patients about so long ago. So for me, it's just, yeah, sparking the curiosity among my peers.
Yeah, I love that. I think it's so exciting. And I know that was my face the first time I used it. I mean, it was just mind blowing. So for those of you out there listening, I highly suggest, even if you just get one opportunity to try it, I think it will literally blow your mind. So thank you, Noriana, for your time today, for your experiences and sharing with us. I really, really appreciate it. It's just something I like to talk about, obviously. And I appreciate your willingness to come on and share.
Thank you, Katie, for having me. It was such a pleasure. I love all the things you're doing and just can't wait to see what you're going to have coming out next and just to thank you for being for the students, right? Because your curiosity and reaching out to other hygienists, you're able to bring that back to them to just keep them well informed with what's going on in our dental hygiene world. So I appreciate that.
Yeah. Thank you. Thank you. Yeah, things change so quickly and our textbooks don't keep up. So we gotta keep our finger on the beat here.
That's so true. So true.
All right. Thank you guys for listening. If you enjoy this content and you value this content, please like, share, subscribe, share with a dental hygiene friend that you think you would also value this content. We put out new episodes every Friday, and so I will see you on the next one.